Hello, my name is Leo. I'm an intensive care doctor working in the UK. Hope you're well. In my previous video, I talked about the clinical presentation to diagnose patients with suspected acute coronary syndrome. I've put the link in the description if you'd like to take a look. In this video, I'd like to discuss investigation, risk stratification, and management of ACS. ECG is important for the recognition of acute myocardial ischemia by identifying acute ST segment and T-wave changes or any new left bundle branch block. In patients with suspected ACS, ECG should be promptly done and interpreted, ideally within 10 minutes. Pre-hospital ECGs can reduce the time to diagnose and treatment, particularly in patients with STEMI diagnosis, so that they could be transported to the nearest cardiac center to facilitate PCI for immediate reperfusion therapy, resulting in rapid reperfusion times and excellent clinical outcomes. If the initial ECG at clinical presentation is not diagnostic, it is a low threshold to repeat for serial ECGs and compare with previous ones, since ACS is often associated with dynamic ECG changes. During STEMI, hyperacute tau T waves and progressive ST segment elevations could occur within 20 minutes of presentation. Persistent ST elevation and progressive inversion of T waves could be seen for hours after presentation. Hours to days later, R waves will be lost and pathological Q waves appear in the area of ischemia. ST segment elevations will start to resolve with persistence of T-wave inversion. Pathological Q waves and T-wave inversions will remain for days or weeks, and ST segments should be completely normalized unless there is ventricular aneurysm. After weeks to months, only pathological Q waves will be left as an indicator of OMI. Changes that I mentioned are quite a textbook picture. Of course, ECG changes in clinical practice are highly variable depending on whether the patients receive the coronary intervention or not. It is always a good idea to discuss ECG changes with cardiologists if ACS is suspected. As an intensivist, in this video, I would like to focus on common ECG changes that we should be able to pick up during emergencies and localize the probable area of myocardial infarction. Now, let's talk about coronary artery anatomy. The anatomy of the coronary vessels could be highly variable between patients. Basically, the main arteries of the heart are right coronary artery, left main coronary artery, which then divides into left anterior descending coronary artery and circumflex coronary artery. Right coronary artery supplies right atrium, right ventricle, some portion of interventricular septum, SA node and AV node. Thus, it mainly supplies the inferior of the heart. Left anterior descending coronary artery supplies the anterior of left ventricle and some portion of interventricular septum. Circumflex coronary artery supplies the lateral wall and posterior of left ventricle and left atrium. The comprehension of coronary artery anatomy will significantly improve the understanding of ECG changes and angiographic findings. So, let's see how ECG leads can be correlated with coronary artery territory and area of myocardial infarction. This is how ECG leads are placed. As you can see, ECG changes will be seen in lead 2-3 AVF if there is inferior MI occurs, and the likely culprit lesion could be right coronary artery. Leads 1, AVL, and V5 and 6 will be involved in lateral MI, and the lesion could be in circumflex artery. We can call it inferolateral MI if ECG changes are present in leads 2-3 AVF and 1 AVL and V5 and 6. In anterior MI, ECG changes will be identified in leads V2, 3, and 4, and the culprit lesion is likely to be left anterior descending artery. If left main stem is affected, anterolateral MI can occur with ECG changes in lead 1 AVL and V2 to V6. If myocardial infarction affects the interventricular septum, ECG changes can be seen in V1 to V3. Posterior and right ventricular MIs are a bit tricky to diagnose, so if abnormal ECG is concerned, cardiology advice should be sought. Biomarkers are as important as ECG in the diagnosis of ACS. When myocardial injury occurs, several biochemical compounds are released into the bloodstream. They are troponin T and I, CKMB, AST, and LDH. Among them, troponin, especially troponin I, is highly specific for cardiac myocytes and also the most sensitive marker, as it can be detected within 4 to 6 hours after myocardial injury, with a peak usually at around 12 to 24 hours. Therefore, troponin is the preferred biomarker and the gold standard for the confirmation of myocardial necrosis. Moreover, there is a strong correlation between troponin level, intracoronary thrombus, and the amount of ischemic myocardium. During the clinical assessment, the trend of the troponin levels are more important than the single value. Hence, it should be repeated after 3 to 6 hours after the first sample. Since raised troponin levels do not differentiate the cause of myocardial injury, echocardiogram plays a major role to confirm the diagnosis of type 1 MI, which is caused by atherosclerotic thrombosis in coronary arteries. We can assess myocardial thickness and motion to detect regional wall motion abnormality, which is the pathognomonic feature of coronary artery occlusion, size and function of ventricles and valves, presence or absence of pericardial and pleural effusions, and volume status of the patients to guide fluid therapy. Not only in diagnosis, echocardiogram is also useful in detection of non-coronary cardiac causes of chest pain, for example, abnormal aortic root and regurgitation in aortic dissection, severe RV strain and massive pulmonary embolism, pericardial thickness or effusion in acute pericarditis, etc. Stress echocardiography, which is done 2 to 10 days after MI, can assess myocardial viability and distinguish non-viable myocardium from myocardial stunning. Coronary angiography is the gold standard for the diagnosis and often treatment of coronary artery disease, and it will usually identify a culprit artery and potentially allow coronary intervention to fix the problem. Cardiologists will make the decision whether the patient is appropriate for cath lab to do the procedure. Nowadays, in non-emergency clinical settings, non-invasive imaging techniques such as CT coronary angiogram, cardiac MRI, and PET scan play important roles in diagnosis and assessing etiology in patients with known or suspected MI. After the diagnosis of ACS, as clinicians, our next step would be to predict the risk of patients to develop advanced events and guide the optimal treatment plan. Assessment of clinical symptoms alone is not sufficient for risk stratification, and the severity of chest pain does not usually correlate with the extent of myocardial infarction. There are scoring systems to predict patient risk after myocardial infarction. They normally utilize patient comorbidities, clinical features, ECG, and biochemical markers. CALIP classification is a very rapid and effective system of risk assessment in patients with myocardial infarction. The higher the class, the higher risk patients are at. Class 1 includes individuals with no clinical signs of heart failure, those with crackles in the lungs, third heart sound, and elevated jugular venous pressure will be in Class 2. Class 3 patients are with features of frank and acute pulmonary edema, and those with cardiogenic shock or severe hypotension are regarded as Class 4. The Global Registry of Acute Coronary Events score, GRACE score, consists of age, history of heart failure or MI, heart rate, systolic blood pressure, ST segment deviation in ECG, serum creatinine and cardiac troponin levels, and number of PCI in the hospital. Patients with GRACE score between 109 and 140 are at immediate risk of in-hospital mortality, and patients who have high risk will be scoring more than 140. Thrombolysis in myocardial infarction, TEMI risk score, is a validated scoring system for risk stratification in acute coronary syndrome. In patients with NSTEMI, it is used to predict the 14-day risk of death, myocardial infarction, or urgent revascularization. As you can see here, to calculate the score, we can use the factors such as age, risk factors for coronary artery disease, previous coronary artery stenosis, ST segment deviation on admission ECG, the number of angina episodes within 24 hours, use of aspirin in last 7 days, and serum cardiac biomarkers. As the graph illustrates, a higher TEMI score correlates significantly with increased number of all-cause mortality, new or recurrent myocardial infarction, or severe recurrent ischemia requiring coronary revascularization. In STEMI patients, TEMI score is used to predict 30-day mortality. We can use the components like age, presence of known diabetes, hypertension or angina, systolic blood pressure and heart rate, Caleb class, body weight, anterior ST elevation or left bundle branch block in ECG, and time to reperfusion therapy. The mortality increases as the score does, as we can see in the figure. Crusade bleeding score quantifies the risk of in-hospital major bleeding in NSTEMI patients after treatments. The variables include baseline hematocrit, creatinine clearance, gender, history of diabetes, peripheral vascular disease, signs of heart failure, systolic blood pressure and heart rate on admission. If the score is more than 40, the patient is at high risk. Now, let's dive into the management of ACS. Acute coronary syndrome is a challenging time-dependent process where time is muscle. If we are convinced that ACS is likely diagnosis, we need to liaise urgently with cardiology team for potential coronary intervention and, if required, transfer to the hospital with specialist cardiac center is essential. Multidisciplinary team members of doctors, nurses, and technicians from intensive care, emergency department, cardiology, and radiology need to work hand in hand for the best possible results. In pre-hospital setting and ED, immediate treatment of ACS should be started as the delay in initiating therapy is associated with poor outcome. Make sure that the patient is maintaining airway and oxygen should be administered via face mask or nasal cannula if the patient is in respiratory distress, and aim SpO2 more than 90% on continuous monitoring. We should put cannula in for IV access and blood samples for biochemical and hematological workup. Arterial line should be inserted if accurate invasive continuous blood pressure monitoring is required. However, right radial artery should be reserved for the cath lab procedure. Continuous ECG monitoring is vital, and repeat 12-lead ECG as needed to keep an eye on dynamic ECG changes. The majority of patients will present with chest pain, so we can consider sublingual or IV nitrates for symptom control, while close monitoring the blood pressure, as nitrates can lead to hypotension, especially in MI patient with right ventricular involvement. If analgesia is not adequate with nitrates, IV morphine can be started as low as 2 to 4 mg, then titrated up as required. Like I mentioned in my part 1 video, myocardial infarction is mainly caused by atherosclerotic thrombosis. Therefore, loading dose of antiplatelet agents are first-line medication to prevent inflammatory process and platelet adherence, which limits and even reverse the formation of white thrombus. Aspirin inhibits cyclooxygenase and synthesis of thromboxane A2, and clopidogrel, prasugrel, ticagrelor are platelet ADP receptor blockers, and the choice of agents depend on the estimated risk and therapeutic strategy. Heparins can be used to prevent thrombin activation by blocking factor Xa and thrombin. Fibrinolytic agents, alteplase for example, can break down red thrombus, and they are recommended within 12 hours of symptom onset in patients without contraindications if timely primary percutaneous coronary intervention cannot be performed after diagnosis of STEMI. If the duration of ischemic symptoms is less than 12 hours, reperfusion therapy is indicated in all STEMI patients. Hence, primary PCI strategy is recommended over fibrinolysis. Let me summarize the critical time targets in STEMI. Maximum time from first medical contact to ECG and diagnosis should be less than 10 minutes. The interval from diagnosis of STEMI to primary PCI should be an hour if the patient is already at PCI center. For STEMI patients who need to be transferred, primary PCI procedure should be able to start within 90 minutes. If primary PCI cannot be achieved within a couple of hours, then bolus or infusion of fibrinolysis should be started in 10 minutes. The efficacy of fibrinolysis should be reviewed in an hour, and if successful, PCI needs to be arranged as soon as possible within 24 hours. Patients with NSTEMI are usually treated with antiplatelet therapies and heparin. Primary PCI is indicated if they have ongoing ischemic symptoms refractory to medical treatment, with dynamic ST segment or T-wave changes, particularly with intermittent ST segment elevation, features of cardiogenic shock, life-threatening arrhythmias, cardiac arrest, mechanical complications of MI such as septal, free wall or papillary muscle rupture, LV aneurysm or thrombus. If pulmonary edema is present, treat with upright posture, IV furosemide, nitrates and morphine. Consider CPAP if the patient is not responding to the initial treatment. Patients with MI and cardiogenic shock can be normally managed in coronary care unit if there is no other organ support is needed. If they present with cardiac arrest and multi-organ failure, intensive care admission is needed for post-cardiac arrest care and organ supports. I have made a video about post-cardiac arrest care, so if you're interested, please click the link in the description. Once patients are stable, ACE inhibitors and beta blockers can be considered if there is no hemodynamic compromise. Lipid-lowering agents, statins, may benefit patients for atherosclerotic plaque stabilization by lowering cholesterol level and by systemic anti-inflammatory effects. Post-MI patients who survive should be monitored and followed up by cardiologists after hospital discharge and should be scheduled for cardiac rehabilitation in community, because in longer term, left ventricle will undergo a transformation of its size and shape through a process known as negative remodeling, and it can eventually lead to chronic heart failure. That's the end of my talk about acute coronary syndrome. Hope you enjoyed it. If you did, please share with your friends and colleagues. I'll see you in the next video. Take care.